is there a naming problem in pure word blindness? My dear friend, in pure word blindness, there is no problem in naming an object. Patient in a three-dimensional view will always look at the object, appreciate the shape, know it what it is. The patient is just blind to words. Okay, is just blind to words. Average word output means that we should have for a fluent speech of more than 4 words at a stretch. Okay. So pure word blindness doesn't have any problem as such for naming. The word which is written in front of the patient, he cannot read that only thing, that is blind only to words. Today topic will be multiple sclerosis, MS, a very important topic. No, see in pure word blindness, there is a disconnection between the visual cortex and the area which I require for finding out the word. Any word which is written in front of me, I always have an image of it stored in the brain somewhere. So the connection of the visual cortex with that area is being altered, not with the area which is supposed to name. For example, I might pick up a bottle to drink water. I know it's a bottle. I might drink water and then look at the label which is written on that, which company bottle. I will not be able to decipher the name of the or anything written on the sticker over there. Okay. What is refractory myasthenia gravis? There is no proper definition. It's a clinical view. When a patient doesn't respond to the pyridostigmine therapy or maybe a good dose of immunosuppressants, but there is no duration as such which we can classify it. Okay. Mollaret meningitis, I'll deal with it separately. Don't worry. We still got 3 more days to cover up. In conduction aphasia, the conduction is being lost somewhere between the Wernicke's and the Broca's area through the arcuate fibers. So the Wernicke's and Broca's are individually working, but the connection is lost. Naming and repetition won't happen, while comprehension will happen and the fluency would be maintained. Why is fluency increase the conduction aphasia? See, what happens is the Broca's area is forming a word and it keeps on putting out that word, right? Now what happens suddenly, the patient will just make a word, give it out, but will not understand the real meaning and the emphasis of that word at a particular situation. That's why I've written a thing up. Okay. Spinal cord, my dear friend, I'll be taking that topic somewhere in the live classroom because it requires from the scratch. The basics has to be very clear. Parkinsonism, yes, the next topic I'll take movement disorder and Parkinsonism. It's more clinical a topic. You'll understand a lot of things. Okay. I know spinal cord is a very tough topic, but it's very easy. We'll do in the live classroom or the VSET sessions that we have later on. Okay. Oh my God, cryptococcal meningitis. Yeah. Cryptococcal meningitis is like stree for me. It's a very old saying, in Kannada, Nareba, which means come tomorrow, and the great movie Stree was made for him on this old saying, the Stree Kalana. So cryptococcal meningitis is a topic that I keep on postponing. Kalana, Nareba. I'll try to do it today if possible, if you got time. Okay. And don't worry. I know whatever are your doubts. I've been following you guys on the Facebook page also. And I know what all extra things that you require. Yesterday I told about congenital myasthenic syndrome. Just one word on it. It's a disease which comes out through the epsilon defect in the acetylcholine receptor. Okay, so there is one epsilon unit of the acetylcholine receptor which is found abnormal in them. Okay, not too much of detail is required on that. MIDAS score, I'll tell you just a word on that today. Okay. Okay, a neuro exam, when will it be held? I'm planning for it. I'll let you know tomorrow. Maybe on the 30th of this month. I think so by tomorrow evening or tomorrow night, we'll put the test live. And the test will only contain the topics which I've done over the last 8 or 9 days. Don't worry. And the last day when we have, I'll take a lot of extra things along with the discussion of the paper also. Because Parkinsonism as such requires around 1.5 days. Okay. Okay, visual agnosia and anomic aphasia. Anomic aphasia is a disorder in which you cannot name a particular object. Okay, object. Visual agnosia is a bigger term. Like you look at my face, you know who am I, right? For example, you know a friend of yours, and next time he visits you, and you know the person by the facial representation, correct? So what happens is that is inability to recognize faces. That's a very old term known as prosopagnosia, in which what happens is that the patient looks at the relatives who have been known to him and friends and just looks at them and doesn't recognize the face. So that's a broader term. Visual agnosia is a broader term in which the patient has inability to identify anything around him. While anomic aphasia will be a condition in which the facial recognition may be fine, but only the object which has been shown to him is being lost. That the thing, what it is and what it is meant for, it is not being told by the patient. I'll give you a simple example. I was once traveling in Delhi in metro, and four of our students, the DAM students, saw me from a distance, and they smiled at me. I also smiled at them, and there was a deja vu experience among each other. And suddenly, all one of the guy among the four came towards me and asked me, "You were also in DAMS, na?" First of all, I could not catch the joke. After 1 minute, the another guy in the group asked me, "Which batch are you from?" I said, "Oh my God, I'm your teacher." So that very commonly happens if you attend these online classes or maybe the VSAT lectures. When you see us live, it's quite a different personality. Okay. So the person who was my student could not recognize me on my face. That's visual agnosia. Simple. Till the 30th of this month, I'll be completing the topics of neurology. Not every topic, of course, because what will you do in the live classroom then? Okay, we'll take them later when the lockdown gets over. Because the may end, the lockdown may end at the May end or May beginning. The May doesn't know when will it end, right? I put a meme yesterday on this. Yeah, clustering of the receptor is the main thing to convert the action potential into the threshold potential. Like for example, there are four receptors all away from each other. All of them come together. There is going to be a good end plate potential and a good action potential. It's a very simple concept. That's a teamwork. We're just 2 minutes away from the beginning of the class. Yeah, AIMS date came today. Dr. Deepu's fan, Dr. Siddharth, the rapper, was telling us that it's on the 5th of June. Then suddenly I realized that is my marriage anniversary. Good. And so let's see what happens on that particular day. Because it's all being taken as a presumptive thing that the lockdown might end and at the May end, and the May doesn't know when will it end. So a lot of ifs and buts are there. Let's be prepared for the particular date that they've given. Okay. Okay, another 1 minute. Yeah, we have one rapper and one memer. A lot of different kind of personalities that we have. Okay. Chalo. Let's start. When someone takes my mobile phone away from me at 7:30 p.m., the Kabir Singh the rebel with a cause comes out and I say keep it back because that's the time for the class to start. Right? Good evening, welcome people who have joined us. Right? Topic for today is multiple sclerosis. Okay. Now, how's your internet speed? Very fast and very high, sir. So how's your Josh? That's very important. It's also very high today. Looks happy. Yeah, happy Tuesday. Some people are wishing me happy Tuesday also. It's a vegetarian day, right? Okay. Now let's begin the class with another very important topic to understand and read. A disease that comes out in the central nervous system, that is multiple sclerosis. Multiple sclerosis. Now MS is a triad again. It's a kind of a not neurodegenerative, but a neurodemyelinating disorder in which three things happen together. So it's actually a love triangle that we find, a triad of three things. The very first thing in the triad that we have is the inflammation. The inflammation. Okay. Second thing that we have along with it is the demyelination. And the third that we have is a gliosis part. Okay. Gliosis means a type of a scarring which appears in a part of the brain that is the central nervous system. Okay. So in the central nervous system, we have got three parts: inflammation, demyelination, and gliosis together happening, which will ultimately relate itself into a neuronal loss. Neuronal loss. Okay. So MS is a triad that we find in this pattern, right? Like, just don't write this down. It's very interesting thing. I'm telling you another triad. Okay. R, don't write this please. R stands for read. R stands for revise. And R stands for recall. If you do these three things, you will have an MS with you. In the exam, you'll have the maximum score. Please don't write this, okay? Just for boost up of your motivation that we have. So MS maximum score in exams, of course, is going to come when you read, revise, and obviously are able to recall everything. Okay. Now, why does MS actually happen in the brain? Now let's go into the pathological process that we have somewhere in a patient of multiple sclerosis. So it's nothing new, it's same thing again. There is inflammation, there is demyelination, and there is a gliotic scar in the central nervous system in MS patient. And it happens multiple times. Now this is a very important concept. It is often disseminated over time and space. Correct? That is multiple times, multiple sites in the central nervous system. Okay, that we have somewhere we find it is seen in the brain. That is known as a term multiple sclerosis. Correct? Now, why does MS really happen? Let's go into the simple pathology or the immunology related to it. Now remember this. There is a myelin basic protein, okay, being abbreviated to me as a word MBP, which happens to be the key antigen. I'm using the abbreviation AG for that. So it happens to be the key antigen to start this immunological problem. Now this key antigen known as myelin basic protein is going to activate cells which are the T cells anytime. Okay. T cells, we know, to some extent are going to flare up the immune reaction, and they might cause one thing, obviously, is a disruption of a blood-brain barrier that we always have, right? Now, simultaneously after this, remember this, there is going to be another cell which gets activated, which you know and understand as a B cell. Correct? And now what does a B cell give me? It gives me the antibodies against what? MBP? No, against myelin. Where is this myelin present? It's in the central nervous system. So I've tried to make it as easy as possible because a lot of facts are there somewhere in this very topic if you try to read it from the book proper. So these are the few basic events that you should understand. How does it all starts and where does it go? Okay. Now these antibodies, are going to destroy the myelin in the central nervous system. Destruction will cause demyelination, and a particular site where the demyelination had occurred, there is going to be no remyelination finally. That is known as a sclerosis. Thus we complete the triad. There is inflammation, there is demyelination, and there is a scarring present at the particular site. Okay. So that's a basic. We'll require this basic again. Okay. Some amyloidosis fugax just happened. Don't panic. Don't panic. Don't panic. All is well. Some amyloidosis fugax just happened. Don't panic. People joining late, I don't know. I'll just repeat. MS is a disease in which we find a triad of inflammation, demyelination, and a scarring seen in the central nervous system, right? Leading on to somewhere a neuronal loss. It all happens again and again over time in space. That's why the word multiple comes in. This is the first slide I'm showing you, and this one happens to be the second one if you take it. The key antigen is a myelin basic protein that activates the T cell, that disrupts the blood-brain barrier. B cell and the antibody go against the myelin. See, this year in NEET PG, we found at least 3 MCQs coming on multiple sclerosis. It was a very important topic, often neglected. Yeah. 5 years back when I used to take out neurology, I never used to discuss this MS as a topic. And students used to ask me why, sir. I used to tell them, see, it's not very important. Hardly one question has come for the last 10 years. Then in one of the AIMS exam, I remember that 6 MCQs came on MS. In one exam, 6 questions came on MS. And suddenly one day I went to a library to see one reference book, and some students were reading and they were looking at me. Okay. And I could do also the lip reading thing. Okay. So they were trying to tell me that because of you, we are sitting here. So it's a very important topic. Don't neglect this one. Now look at the clinical features. Very important. Number 1 happens to be the sensory symptoms. So there are a lot of sensory symptoms that we come across in these patients of MS. What are the sensory symptoms? It can be paresthesia. Paresthesia. The word paresthesia, if you remember, is a clinical term which means tingling. Okay, it can be a simple needle-like sensation that you find in the patient. Among all the symptoms that we have somewhere, in the recent data, they found that paresthesia happens to be a very common one among all. So it's one of the very common symptoms in patients of MS, paresthesia. Second one is a term that you all should know is dysesthesia. Now dysesthesia basically means a burning sensation. So there is a burning sensation felt in the patient that is known as a dysesthetic pain. So there is one tingling paresthetic, then there is dysesthetic. Then we have another symptom, that is hypoesthetic or hypoesthesia. That means the sensory loss occurs in this stage. So this patient cannot feel anything, that is hypoesthesia, or maybe total loss anesthesia. They can be extra, that is paresthesia, or can be dysesthesia. Anything can happen. So remember a few points about the sensory symptoms that happen in these patients. Second thing that we find in these patients is often optic neuritis. Optic neuritis. Now this is a topic often from ophthal. Don't worry, you'll try to take it out from there and try to understand it better. I'll abbreviate this as ON, or optic neuritis. Now what we find in optic neuritis patient, they got decrease in the visual acuity. There is a decrease in the visual acuity seen in the patient. Okay. Also in these patients, don't forget, they also have got decrease in the color perception. So color loss, they can get color blind also, they can have a visual loss phenomena as well. Don't forget, apart from this, in these patients we often get periorbital, a typical periorbital pain. Okay, so around the eye there is a peri or a retroorbital. It can be retroorbital also, no problem. which often typically happens more on movement. So whenever the patient moves the eyeball, they find a typical pain happening in them. It can be peri, it can be retro, yes. And you know, somewhere if you read this topic out from your opthal textbook, the fundus, yes, the fundus examination is considered to be abnormal in these patients. What do we have? Initially, we might have it as a stage of papillitis, okay. Then we have an optic atrophy in these patients after that. So there can be a stage of papillitis followed by a stage of optic atrophy that could be seen in this patient. Do remember this, in these patients of MS especially, pupillary defects can happen, but so one symptom or one part of the disease, that is uveitis, is not seen. So this has been a question somewhere from opthal, is uveitis seen in patients of MS? No, it's not seen. Are the pupillary defects found in them? Yes. Please do remember this, that in patients of MS, especially I'm talking about MS, optic neuritis is often seen to be unilateral. That means all the problem of the eye that we find is always on the one side. It's a unilateral kind of a problem, not a bilateral. I agree, bilateral can happen, but the unilateral presentation is more common in them in patients of MS. Okay. Then after this, we do have in the patient weakness as a symptom seen. Weakness. In the patients of MS especially, there is going to be an exercise induced weakness that we find. Okay, so the more they try to work out, do some exercise, they get more and more weak. If you can tell me what symptom am I coming closer to, as a said thing, that if a person is working out and is getting weak, okay, can you connect with this symptom? What symptom am I really talking about? It's somewhere which is quite close to a disease of myasthenia, if you remember. Yes, the easy fatigue. So fatigability or maybe an easy fatigue could also be seen in patients of MS. But very important, very important, easy fatigue in patients of myasthenia, easy fatigue in patients of MS. That's the problem now. How do you tell it's a MS case or not? One thing remember, it's a disease which is demyelinating, degenerative, after demyelination of course, MS in central nervous system. Got? So these patients of MS are going to have one sign of UMN kind of a lesion, what? Spasticity. So it is an exercise induced weakness, easy fatigue can happen, one thing, along with spastic phenomena also seen in them. That's very typical, right? Now number 4. In patients of MS, we do find them having a lot of other symptoms, like diplopia could happen. Diplopia. Why does diplopia happen? Now that's a very important thing. Why does diplopia happen in these patients? If you come back somewhere from opthal classes, you'll really know what is the reason of diplopia in these patients. Now to understand that concept, let me draw a simple diagram. How do we move the eyeballs? Just look at me, don't write. For example, I'm looking at something moving in front of me and my eyeball is moving like this, okay? And you can see both the eyeballs are moving like this. That means this eye is getting abducted and this eye is getting adducted. Now if I move the eyeball like this gets abducted, this gets adducted. This is a simple thing. Now for example, boys are studying in the library, yeah, they see some girl moving around them, they just keep on staring at her when she is moving. So they say like this, the boys stare and the girls investigate. They come to know what's happening. Okay, bad joke, but reality. Now, how does my eyeball move? That's very important. Whenever I'm getting an input in the occipital lobe, I'm going to get a signal to of eye field in the brain known as a frontal eye field. Okay, so I'll draw the diagram to explain this concept what I'm trying to tell you about. So I'll make two boxes right over here above. I'll take them as frontal eye field. Frontal eye field. Okay, FEF. FEF. Okay, so there's a frontal eye field somewhere above which is guiding me to move the eyeballs. But how does it move? If I take this one eye, for our convenience, I'll write this as the left one and this one as the right one. Okay, so what happens first of all, I want to look towards the right side. The left frontal eye field will fire, will give a signal to this eyeball on the opposite side. Look at the direction please, to the opposite eyeball, and this eyeball will automatically abduct by the muscle known as the lateral ictus, correct? While this one on this side, this muscle will adduct, move towards the center adduction by the activity of the muscle medial rectus MR. What we find is this one is being supplied by a cranial nerve whose number is 6, LR6, yes. This one is supplied by a cranial nerve whose number is 3rd, MR3. So medial rectus is supplied by the 3rd oculomotor nerve, the lateral rectus is supplied by the 6th nerve. Now we have to send a signal from this end to this end. Now look at this please. This is a kind of a signal which will go from the 6th on this side to the 3rd of the opposite side. Yes, that is known as the MLF that we know, the medial longitudinal fascicle. Okay, let me draw this in a different way in a longitudinal diagram. Okay, now like this one and this one. This one is the 6th cranial nerve nucleus. This one is the 3rd cranial nerve nucleus. I've drawn 3rd above and 6th below for the reason because the 3rd nerve nucleus is located where? We know the brainstem, the uppermost part, the midbrain. 6th cranial nerve, below that is the pons. That means somewhere a signal from this side 6th will go to the opposite side 3rd to move the eyeball on that side. And this signal very well goes up with the help of what? MLF, known as medial longitudinal fascicle. Very well abbreviated to me as a word MLF. Okay. Why is it known as medial? Because it's in the midline. Why is it known as longitudinal? Because it's going up and down. No, not down but up, and it's a bundle of fibers known as the fascicle. You want to repeat? It's very simple. You can see the diagram. Frontal eye field on one side activates, sends a signal to the 6th nerve to the opposite side, which will move the muscle lateral rectus and abduct the eyeball. The medial longitudinal fascicle will try to cross the signal opposite side to the 3rd nerve where the medial rectus here will contract to abduct the eyeball. Okay, I'm not going into the PPRF. I'm not going into the complexity. I'm trying to make it as simple as possible. PPRF drama is something different. We leave that. You'll read an optal, don't worry. Time aega. Now tell me, if I break this MLF, what will happen? Okay, so I create a lesion at the level of MLF. I create a lesion at the level of MLF. I'll take you here. This is the right eye and this one is the left eye. Please look at the diagram. It's very clear, very simple. This one is the right eye and this one is the left eye. Okay. So what we have now, if the lesion is at the level of MLF, the medial longitudinal fascicle, tell me please, will the right eye move away from the point where it is sitting? Will it abduct or no? So I'll make this as right, make this as left. Tell me please, will the right eye abduct or no when the lesion is in MLF? Yes, it is going to move away from the source, from the midline. Why? Why? Because it's getting a signal from the frontal eye field. When it's getting a signal from the frontal eye field, it will catch and take it away. Simple. While the left eye, the opposite one, will it adduct? That means will it move towards the midline? Obviously no, because it is not getting any signal from MLF. Now find this out. These are the eyeballs. Okay. This eyeball will move away, while this eyeball will remain in center. If I take this as left, take this as right. Got my point? Correct? What is this drama known as? Can you type me the abbreviation of this drama? If you have read Opthal, it's a must know topic. It is known as nuclear ophthalmoplegia. Yes. Why such a name came for it? Ophthalmoplegia is a weakness of the eye muscle. Look at this please. The lesion is between the nucleus of the sixth and the third. That is, the lesion is at the level of MLF, known as internuclear ophthalmoplegia. Okay? Right. So this is a presentation. Now that's the reason for diplopia. The eyeball moves on this side and the other eyeball doesn't adduct. So they will have two images on two retina and they'll look 2 in 2. Okay? This happens in MS. But this happens in multiple sclerosis, I know. But in patients of MS, we might also see bilateral INO. Now find this out name. One INO and both side INO. Okay. Look at this. This is the sixth. This is the third. A signal from this side to this side is being carried by what? MLF. Correct. As well as sixth of this side and the third of the other side. Now the signal is again carried by what? MLF. It is known as internuclear. Why internuclear? Because the lesion is between the nucleus of the sixth and the third nerve. Look at this now diagram again. Sixth nerve of this side is connecting with the third of the other side. Sixth kidney nerve of this side is connecting with the third of the opposite side. So there is a MLF like this and there is a MLF like this in the eyeballs which are there. Okay. Now bilateral INO. Why bilateral INO? MLF of this side and MLF of this side, both sides are destroyed. Now please tell me the direction of the eyeball in this patient. The easy guess. People are reading, studying good. Some people are still worried about the length of the classroom, teaching 8 hours and all. See, you guys take so much time to understand a simple topic. 8 hours is also less. Please tell me, where will be the eyeball look? It's very simple. Look at this please. Frontal eye field will send the signal to the sixth kidney nerve of this side. Sixth kidney nerve will abduct this eyeball. Okay. Frontal eye field from the other side will give a signal to the sixth kidney nerve of this side. And the eyeball will move this side. Look at this. This eyeball looks there. Both the eyeballs look laterally. As if I am looking at the wall. Okay. Walled eye. Walled eye. Walled eye. Bilateral internuclear ophthalmoplegia. Someone wrote the right name. Webino. Webino. Walled eye bilateral internuclear ophthalmoplegia. Simple. So my dear friends, I know you are sitting with some distraction, mobile phone right now. Pay attention. It's a very easy thing if you try to catch with me in the classroom itself. वरना बड़ा पछताओगे. मेरी क्लास में जब तुम सोते जाओगे बड़ा पछताओगे, बड़ा पछताओगे. Okay, sorry for some sarcasm, but you guys really need a wake up call. Yesterday I was telling you it's not a Karan Johar movie that we are facing. We are in a crisis. We are in Yuri. So how's the Josh? It should always be high. Okay, loud please. Okay, I'll bring out the Arnab in me out. I'll be more loud. Don't worry. Somewhere after marriage, I've lost all my voice also. No. Now the fifth thing that you might have in the patient is ataxia. Ataxia. Now ataxia happens in these patients due to cerebellar lesions. Cerebellar lesions. Remember this. Cerebellar lesions are something which we have in them, right? In which we find in them that suddenly they got some demyelinating lesion in the cerebellum and they have got a typical swing gait, that is ataxia. Number 6, or I can put this one. Ancillary symptoms. Ancillary symptoms. So 2 minutes of silence for the people who are sitting with the photocopy notes right now, because what is given in the photocopy notes and what's going on is totally apart. Okay, so 2 minutes of silence of some people would take a shortcut but landed somewhere else. Ancillary symptoms. What are ancillary thing? If you go out in dictionary, you will come to know that somewhere it's a supportive kind of a thing. So there are many kind of supportive kind of symptoms in MS that will always support my diagnosis. Okay. For example, it can be some paroxysmal symptoms. Okay, which is divided in the book as a paroxysmal symptoms. Right. So certain kinds of paroxysmal symptom that happens once in a while and keep on going like this happen in these patients. That means these symptoms are of a brief duration. For example, somewhere from 10 seconds time to 2 minutes time. And it might happen in a particular frequency of approximately 5 to 40 per day. So there are some additional paroxysmal symptoms which do happen in patients of MS, which are brief and very frequent and very recurrent. Okay, what are they? One of the symptom which is a paroxysmal symptom in them is a heat sensitivity. One of the symptoms that we have in them is a heat sensitivity symptom. What are these heat sensitivity symptoms? Right, in this patient there is a unilateral visual loss, or could happen as blurring also. Yes, on exposure to heat. Now this has been a very old question. What is this collectively known as? It is collectively known as the Uthoff sign. So all this drama is collectively being known to me as a sign known as the Uthoff sign. So Uthoff sign is a sign which is a heat sensitivity paroxysmal symptom, okay, in patients of MS, in which there is a loss of vision and blurring on exposure to heat. Now, can you tell me one disorder which this aggravates on heat, one disorder which actually improves on cold? Can you tell me one disease which actually improves of cold environment? That means a person is given something cold, he feels better. It's a neuromuscular junction disorder that we covered earlier, known as the GRADE disorder. Yeah, myasthenia gravis. Why? Ice pack test. You put the ice pack on the patient's eyelid, it will inhibit the acetylcholinesterase enzyme. Okay, simple, clear concepts. Good. I still remember this question came in exam first around 5 years back. IcePack test is done in. Even I did not recollect that, and students recollected it, and everyone marked the answer as multiple sclerosis, and they were very proud of their answer. I asked them why. They all gave me this funda, sir, look at MS. All these symptoms of visual loss increases on exposure to heat. So whenever I apply the ice on them, they will feel better. Oh my God. That means my patient of MS should go and do an ice bucket challenge every hour to feel better. Okay, no, it's not connected to that. Another symptom that you all should know as a sign, as a name, is a Lhermitte. Lhermitte sign, or a Lhermitte sign or a symptom. Okay. Lhermitte sign or a symptom is a sign which is seen in these patients in which you find a shock-like sensation over the spine radiating to the lower limb in the patient. So that means there's a shock-like sensation over the spine, okay. So sorry for my bad handwriting, that's my font actually. Radiating to the lower limb on flexion of neck. So when we flex the neck of the patient, suddenly what happened is that there is a shock-like sensation over the spine radiating down to the lower limb. That is known as a Lhermitte sign. It's a very non-specific kind of a thing, can be seen even in a cervical spondylosis cases. Okay, just remember these two ancillary symptoms which are add-on symptoms. Now comes the confusion and maybe a sort of a controversy that which is the initial symptom and which is the most common symptom in patients of MS. Let me take this out away from Harrison, because Harrison has given a very old data somewhere in the new data that we have. You know, when I look at the first symptom of MS, they are usually sensory. Okay. Now I want to make this clear. It's not the sensory loss which I might have told you in the previous classroom teachings. Is paresthesia that we find in these patients. Okay. The second symptom could be motor, which is weakness, right? And now in a study quite done recently, they gave optic neuritis. I remember I still used to teach last year somewhere kid optic neuritis is one of the very common symptom. Now they put it as third. So first, second and the third. Life is a race, at least remember the first three. But when they ask you the most common symptom of MS, now there are two questions. The earliest and the most common, they are two different things. When they ask you the most common symptom, go with weakness. Then we have the sensory symptoms. Then we have the ataxia also. Okay. So when I look at the symptoms which are most common in patients of MS, it can be weakness, it can be sensory, it can be ataxia, in this order which we take it. Yeah, optic neuritis, I just forgot to tell this one, because most of the books which I have seen, they've given sensory oblique optic neuritis. It's fine. So if you want to ask me what is the most common symptom in MS, it's weakness. But what is the earliest symptom in MS that you find is sensory. That is paresthesia. Okay. So that's about the clinical features. There are very varied kind of symptoms that we find in them. Now, very important thing. What are the types of MS that we find in a patient? Multiple sclerosis is a disorder, okay, that we find in various types in MS patients. What are the various types of MS that we collect and see? To understand this, we will make a simple graph like this, the x-axis and the y-axis, right? So we have got on the x-axis somewhere the time that we have, and the y-axis we take it as a disability. Okay. So what we find in a graph like this is a patient of MS who comes to me like this. Look at this graph, please. There's a graph at which time we find that the relapses happen in patients of MS. There are many disorders MS and in which we find somewhere the relapses keep on happening. Now this is which is known to me as a type. Relapsing. Some of the authors have still been using the word remitting type of multiple sclerosis, being abbreviated to me as a word RRMS. Somewhere in the latest textbooks we find that around 90% patients with MS have got this type now, RRMS type. Extra point to be added on this, that this disease MS is more frequent in females than males. One thing is very clear, it's more frequent in females than males. And we find the average age of onset, or not the average, the range of age of onset that we find in them is between the age group of 20 to 40 years. So age group of 20 to 40 years is considered to be the age of onset of this disease. Just an additional point to put at this point. These patients often are having vitamin D deficiency. A low vitamin D level is found in most of them. Okay. And there is another infection that we have with them, that is an Epstein-Barr virus. There has been a preceding infection by an Epstein-Barr virus in these patients. It's been a common associated thing with them. Okay. Now another serious type of MS. So this was RRMS type. Okay. Second one is known as the primary progressive MS, quite often abbreviated to me as a word PPMS, primary progressive MS. Now how does PPMS patient behave? It goes like this. Look at the name itself. It's progressive from the very beginning. The word is primary. The disability with time keeps on increasing. It never comes back to normal. Only 10% patients with MS have got this type, PPMS type. Additional facts now. We find this disease is equally common in males and females. So now that's the difference now. RRMS type has female predominant disorder, while it's male and female both. Onset at the age of 40 years. Now if I take the average on the RRMS type, it was 20 to 40, I take it as average of 30 years. Here it is 40 years. And we can see one thing clearly. Disability in this patient is very fast. That means they don't have any time to recover at all. So that's few points about the term PPMS. Third, is a type like this, in which 2-3 relapses do happen, and suddenly in the patient there is a escalation that occurs. That means this was progressive, PPMS, and this one is also progressive but became progressive later on. So I'll label this as a progressive MS, yes, but the name I should better give it, to give it a good meaning to understand, is that it becomes progressive later on, known as secondary progressive kind of an MS, SPMS. Okay, SPMS. Now what is the drama behind SPMS? Please write this down. There is almost 2% risk per year. There is almost 2% risk per year. Okay, for a disease like MS. Look at this now. RRMS was a type which we found, and it became PPMS after that. So there is always a 2% risk per year for this disease to come in a patient of MS. Then the fourth type now, which has been included into Harrison, is about onset MS. Now if you Google out this word bout, it means an episode of MS. But how do I look at it? It could be like this, simple. Single episode of MS. Look at this, a single episode of MS. Sometimes a patient comes to me with optic neuritis, for example. I end up getting his MRI done. I find the typical MRI changes. I get the CSF done. I find the oligochoroidal band. and that's the first episode. So I label this as the episodic MS or a bout onset MS. There is no data too much available how many percentage of people are like this. But the problem is this: if I leave it unattended, it is becoming relapsing over time and time, because this is a problem which is disseminated over time and space. Okay, there was another type known as relapsing secondary progressive, that has been removed now. RPMS, it was a name. Leave that thing. In the latest edition of all the textbook, they've removed this one, that one, the previous one. Bout onset is still recognized. Okay. Now, just a fact to write: genetic consideration, because the question came on this also last year. I remember this topic. Genetic consideration. Like, how do we find somewhere a disease in the family tree? Now, every disease has got an HLA gene with it. Yes. So HLA-DRB1 gene is associated with this disorder. So there is one gene, HLA-DRB1 gene, which has been associated with this. And approximately there are around 200 genes that we know in the whole genomic environment which are associated with this. So we have one gene that we just name it as HLA-DRB1 gene. But what is the risk? What is the risk of MS if your parents or your sibling is affected? Write it down. 1 in 3 if your identical twin is affected by the disease. If your identical twin has been affected by the disease, identical twin, okay. 1 in 25 if your sibling is being affected by. 1 in 50, right, if your parent is being affected by the disease, parent. 1 in 100 if your first cousin is affected by the disease. 1 in 1000 if any family member is affected by the disease. Okay, apart from the first cousin, sibling, parent. Okay, so these are a few risk factors that we should know about the genetic consideration of the disease, right? Because a question has been asked on it, that's why I'm emphasizing on this concept. Now let's go into the investigation part. Oh, before that, very important, staging. A patient of MS keeps on coming to me over and over again. I want to know how good and bad are they in the whole disease process. Okay, so we need to know a staging process in them. Yes, the name of the staging score is extended disability scoring scale, EDSS. I don't know, some of the authors have put it as disease scoring scale also, but it always looks at the disability in the patient, so EDSS is a better term. Okay, now what we have in the scale, there's a scale from 0 to 10 that we use in them. Okay, so 0 to 10 is a scaling system in this. Just remember one point: normal is a 0. Okay, so 0 is good for the patient, and 10th, number 10 scale, is a death that we have of the patient, right? Now we have few factors here to remember. I can just divide this as 1, 2, 3, 4, 5, 6, 7, 8, 9. So this is something that we have as a scoring scale. 0 is normal and 10th is death. Okay. Now what we find is that 1 to 2 scale, or maybe 0 to 2 scale, can be a normal finding. The word normal finding basically explains like it can be a simple optic neuritis, it can be a simple sensory loss, normal findings of MS, no problem in that. While a scale of this and this, 2.5 to 4.5, sorry, 2.5 to 3.5, a scale of 2.5 to 3.5, okay, which means impairment. Impairment in the sense of some kind of weakness or paralysis. Now, paralysis can be one-sided body weakness, heavy paralysis, or it can be paraparesis, right? Now, 4 to 5.5 is a person who is found to be ambulatory. He cannot move around. It's ambulatory person, right? A score of 6, the person uses a cane to walk, okay? A score of 7, the patient uses a wheelchair to walk, okay? A scale of 8, the patient is totally bedridden or bedbound. And scale of 10, you know the person is dead. Now, why am I telling this? Why am I telling all this story? Because I remember in JIPMER as well as NIMHANS, we got a question. Patient is known to be ambulatory, cannot move out so well, requires support. What is the scoring scale in the EDSS of MS patient? It's between 4 to 5.5. Okay, 2.5 to 3.5 is not ambulatory, he just have some weakness. 0 to 2 basically means a normal finding. 6 uses a cane, 7 uses a wheelchair, 8 is bedbound, and 10 is dead. Okay, so as the time passes on, every time I attend a patient of MS, I evaluate the patient on this scoring scale EDSS. How good and bad are they? Paralysis means weakness. Okay, simple questions. Right. Now let's look into the disease proper. How will we investigate the patient? Okay. Like I'll just give you more staging or scoring scale list that we have. What about 9, sir? There's nothing about 9 given. Okay. See, when you reach a number, you get a disability maybe. 9 may be just about to die. Okay, he's about to die. But that's a very bad thing if you can talk about the patient. Do not go into too much detail. Just remember this 0 is normal, 10 is death. Between them, there can be a lot of disability coming in. Okay. Now, EDSS scoring scale was a scale which is applied in patients of MS. The word ambulatory means requires support for movement. Ambulatory. You go to hospital in ambulance because you don't have your own vehicle. Okay, ambulatory, ambulance. Okay, because if you got COVID infection, they will bring a full barat for you, and the ghodi that you will always sit on is the ambulance. The whole mohalla will know about you that you are getting married to the COVID. So, will you be my quarantine? Should be you're saying, not Valentine at that moment. Bad joke. Now, there's another scoring scale that we know is Hunt and the Hess scale. I'm just telling you the names of it. Cane, Are Baba, cane, chhadi, caning. Forgot school. Uses a cane to walk. Okay. Asking simple general knowledge doubts today. What's happened to your IQ in lockdown? Hunt and Hess scale is a scoring scale that is seen in patients of SA, subarachnoid hemorrhage. Okay. Read the names, not too much of detail is required. Osserman grading. Osserman grading, okay, is done in patients of myasthenia gravis. Osserman grading is done in patients of myasthenia gravis. Okay. Apart from this, there's another scoring scale that we apply in patients of migraine. That is the Midas scale. Migraine. Right? What is the full form of Midas? It's very simple. It's migraine, disability, or disease. Some people put it as disease, assessment, score or scale. MIDAS, MI, migraine, D, disability or maybe disease, A, assessment, S, scale or score. MIDAS score, right? Now, just for a review, please remember there is another scoring scale that we apply in neurology practice. The name is ABCD2 score. Now, this is a score which is known as ABCD2. It's not the name of that movie where they were dancing. It is applied in patients of transient ischemic attack or TIA. There are few factors in the ABCD2 that we took out. One is the age of the patient. B stands for the BP. C stands for the clinical symptoms. And the 2D stands for duration. And the worst D, none other than diabetes. Okay. So TIA is a younger brother of a stroke patient, transient ischemic attack. Okay. So just remember the names of various scoring scales that are applied in various disorders. Then we have the investigation part. Investigation can be done by a non-invasive thing, that's the MRI. See, I'm limiting myself on MRI of MS patient because a lot of this is will require a basics of radiology also. Whenever you come in radiology classes, you'll be able to understand them better. But just remember one thing. Abnormality in MRI is present in 95% of patients. So patients of MS, yes, abnormality in MRI is seen with them, 95% of them. Now what do you find actually in these patients? You might see areas of loss of myelin, demyelination, okay, and you might also see areas of no remyelination or a plaque seen, and very typically both of the things are typically seen in a location known as the periventricular location. So the location that we find this kind of a problem, yes, is periventricular in them. Apart from periventricular, yeah, Dawson fingers is a good name, people know it. Apart from this, they can be also juxtacortical. They can also be infratentorial, or they can also happen in the spinal cord. So these are the few areas where you find all these kinds of MRI changes. We might see it in periventricular area, it can happen juxtacortical, it can be happening infratentorial, can be happening in spinal cord. Okay, right. Now a word on CSF. Now CSF is something very important in patients of MS when I look at them, when I want to diagnose them. What do I do in the CSF? First of all, the CSF picture. Will it show any kind of pleocytosis, protein, glucose, something? No. Remember this. In patients of MS, okay, there is ideally no pleocytosis seen. The cell count usually remains normal. It actually increases in just 25% of the cases, not in every patient of MS. If at all, the cell count, if at all, the cell count in these patients, if at all the cell count in these patients is found to be above 75 with a protein above 100, then we have to think for an alternative diagnosis like infection, or it could be a simple neoplasm also. Because sometimes they do come to me with some kind of a demyelinating picture. Okay. As far as the protein is concerned, it is mildly raised in these patients. Not too much raised, it's mildly raised in these patients, mildly raised. Okay. In the CSF of these patients, I do get IgG levels to be high. So IgG levels in these patients is often quite commonly seen to be high. Now coming to you, what you're asking me. When I go and check out these patients on an agarco's gel electrophoresis, yes, agarco's gel electrophoresis, like this is an agarco's gel, we separate various bands inside it by electrophoresis. Now what do you find in MS patients? A very famous thing known as the oligoclonal bands. So oligoclonal bands are somewhere seen in patients of MS. And we might see two or more than two oligoclonal bands in them, abbreviated as a word OCB. But the problem is, right, two more problems. Oligoclonal bands in MS patients in CSF is usually absent at the onset and they increase with time. So initially they might be absent also, but with time we find it to be increasing. Okay. I think so. It's agarco's only, not agarose. It's agarose gel or agarco's gel. My English, please correct me. Okay, is it agarose or agarco's? Sorry for my English. Right. Now, oligoclonal bands in any form, they are positive in 75% of cases. Yeah, it's agarose or agarco's. We'll just check it. We'll just check it once. Okay, is seen in them. Okay. For a better synchronized internet, will take small 2 minutes Maggie break. Right, I'll prepare Maggie and come back. Okay. And I'll check your doubt also, it's agarco's or agarose. Right. We'll just take a break for 2 minutes time and come back. And I've cross-checked, you are right. Some people are good in English and grammar as well. This is agarose gel electrophoresis. This is agarose gel electrophoresis. Okay. So just correct it. Rectification is agarose gel electrophoresis. I'll just repeat the CSF involvement. In CSF of patients of MS, we don't find pleocytosis. It might just rise in 25% of the cases. If at all the cell count is more than 75, protein above 100, think of infection or neoplasm. Protein is mildly increased in these patients. They do get a IgG levels high. And agarose gel electrophoresis will reveal oligoclonal bands which are two or more than two in number. They're often present in 75% of the cases. They're absent at the onset and they increase with time. Okay. There is a diagnostic criteria that we apply in patients of MS. Remember this. In patients of MS, we do follow a diagnostic criteria whose name is McDonald criteria. So there's a criteria which we follow in MS patient known as the McDonald criteria, okay, which is applied for diagnostic purpose. Now, should I read that much to understand this criteria? It's not required at your level. Just remember the name McDonald criteria in patients of MS, okay. In ABCD2, the D stands for diabetes and the duration of the weakness, and the last D stands for diabetes. My Maggie. Okay, I'm like Rajnikant, I just see Maggie and eat it. Okay, I already had my Maggie full. Now let me look into the treatment part. Remember this, the treatment part of MS patient will be from an acute attack. which they do complain with. In an acute attack of MS, don't forget, they have got a very good steroid with them to be given, methylprednisolone. Whenever I use methylpred in these patients, I give it at a dose of approximately 1 gram per day for a duration of 3 to 5 days. Right. After the methylprednisolone, I wait. In case there is no response in these patients, then in that case, I will go for the plasmapheresis. So the drug of choice, if they ask you, is a very standard question. For an acute attack of kind of a MS patient, the fresh attack, you could go and mark methylpred. Okay. Then we have various kinds of drugs. Oh, a lot of drugs are there, which are referred as a disease modifying agents. There are various kinds of drugs which are referred as a disease modifying agent in these patients. Now, there are three groups that we put them into. One drug group which is referred as the highly effective. Then we have moderately effective. And then the third type, or the third name, if you want to write, what should you write? It's highly effective, one drug. One is moderately effective. Okay. Yeah, Ankit has taught you this topic today. It's very good. It's a very good teacher. What should be the third name? Least effective? Least effective? No. It is modestly effective. Now look at the Furago of Harrison. As if Harrison was written by Shashi Tharoor. So the word that we apply here is not effective, not mild. It's modestly effective. Look at the Furago now. Highly effective. Now Shashi Tharoor on one end. On the other end, there is a leader who is highly effective, who is controlling the country right now. None other than our great Prime Minister, that is Namo, Narendra Modi. Okay, Mitron. Okay. Now, why did I make this mnemonic Namo? Just to remember the drugs. Natalizumab, Eli, Mituzumab, Mito, Xantron, and Ocrelizumab. Okay. So to all the bugs in the crowd, I'm sorry, apology for that. I made a mnemonic. Now F and D. There are two more, F and D, which are moderately effective. F stands for the drug whose name is fingolimod, and D stands for the diethyl fumarate. Diethyl fumarate. Modestly effective. Modestly effective. I, G, and T. I, G, and T. That is interferon beta, glatiramer, and teriflunomide. Teriflunomide. Okay. Right. So these are names of the drugs that are used as a disease modifying agent in these cases. Remember a few points and extra things to remember. Among all the drugs till date, we have tried to work them on the EDSS scale and a comparative thing. At least in patients of MS, the best among all is considered to be a natalizumab. I agree, metoxantrone by some authors have been given, but American Neurology Association clearly specifies that natalizumab is one of the best, right? But the problem with natalizumab, can you tell me that problem? What is the side effect? Side effect of natalizumab therapy. If you remember the side effect, it is PMLE, progressive multifocal leukoencephalopathy. If you remember this, that was a disease caused by the JC virus in which there was a person who dies without treatment in 3 to 6 months time. Now that's the paradox. You think the natalizumab is something as a brahmastra, right? But it comes back to the patient as a boomerang to kill him because of this side effect PMLE. So please do remember, in American as well as the Indian society, when I look at one drug that we always start with is interferon beta. Now, if the patient doesn't improve or respond as per the EDSS scale, then we might have to change the drug. Okay. Few extra points now. One drug which is considered for PPMS patients. Now, all this drama which I've written above is RRMS. 90% of the patients are of the RRMS type. So disease modifying agent, whenever we think about, is for the RRMS type, the most common type. Okay. Then we have the PPMS. PPMS is ocrelizumab. I think so. Ankit keeps on telling about this also. Ocrelizumab is a drug which is very well approved for patients of PPMS type. Okay. What about the patients who are of the SPMS type? Is something different in them? In them, we go in for interferon beta. Now, there is a controversy, I agree, but they say interferon beta in the high doses. Okay, for active cases. For the active cases, we give interferon beta in a very high doses to the patient. Okay. So, a few points to remember: the names of the drugs. Need not remember the spelling, at least. Remember the names, more important. Now, there are two more things that we need to know. There's a term known as acute MS. Acute MS. Now, what is the term acute MS? Is it the bout onset MS? No. This acute MS is also known as the Marburg variant. Marburg variant. Okay. Marburg variant is a fulminating or fulminant, demyelinating, disease in which in the patient death occurs in 1 to 2 years of time. In a span of 1 or 2 years, the patient actually dies. That's the problem. Okay. Most of them, there is no remission in them, and it's most of the time found to be idiopathic. There is no clear reason behind this Marburg variant. Okay. So these are few things that we need to know about the Marburg variant of MS. Okay. Apart from this, we also know what are the factors which are good and bad for the patient for prognostic purpose. Prognosis. Remember this, there are good factors or factors for good prognosis, and what are the factors in MS patient for poor prognosis. Okay, Ankit told metoxantrone. I'll just cross check with him once. Don't worry. That's why I'm using. I think so. He must have told metoxantrone for SPMS type. Am I right? Am I right? For SPMS type, he must have told, or PPMS type. Okay, I'll just cross check with him. Okay. Prognosis, good or bad? Good or bad? Okay. Leave it. Don't worry. We're not running anywhere. Any controversy among the faculties, we'll try to sit down together and we'll solve it for you. Don't worry. I'll put an update on this. Good prognosis, they say, is optic neuritis and sensory symptoms at the onset. So when the disease really comes in, optic neuritis and sensory symptoms at the onset is considered to be a good prognosis. Okay. If there are 2 or more than 2 relapses in 1 year, it is again something considered to be a factor for good prognosis. And minimal impairment at 5 years of the disease from the onset, of course, is again considered to be a factor for good prognosis. Now, what is the factor for poor prognosis? Think about it. It can be a truncal ataxia caused by the cerebellar lesions. If the patient comes to me with some kind of a Ullmann or a pyramidal symptoms, okay, and of course if it is a kind of a progressive disease. So there are factors which is somewhere considered to be kind of a prognostic factor for MS patient. If they got optic neuritis and sensory symptom at the onset, it's good prognosis. Less than 2 relapses in 1 year is good prognostic factor. Minimal impairment at 5 years, yes, is something considered to be good factor. Poor is truncal ataxia, pyramidal symptom, and a progressive disease. Okay. Less than 2 relapses in 1 year. Less than. Okay. There's another disease that we have with us known as the neuromyelitis optica, which is a brother of MS, NMO, also known to me as a Devic disease. So there's a disorder with us which is NMO or a Devic disease. Okay. NMO. There's not much of role of IVIG in MS patients. Most of the time in the ward when I get them, I start them on methylpred with plasmapheresis and then put them on a disease modifying agent. And every time they come to my OPD, I try to assess them on the EDSS scoring scale. Okay. Not too much of role of this. NMO, Devick's disease. Remember the point in Devick's again. It's a disorder which is more frequent in females than males. One thing. It is the onset part that we look at. Occurs somewhere in the childhood. One. And can occur also in the early adulthood. So we find this problem coming quite often and common in the childhood days and early adulthood phase of life. Like we find somewhere that in patients of MS, the onset was between 20 to 40. Here it is quite early in the disease NMO. But why is it connected with atopic MS? Now this is important. These patients have got optic neuritis, ON, optic neuritis, which is most of the time seen to be bilateral. Now look at this, they've got bilateral optic neuritis. That is a major difference now. In MS it was unilateral, it's bilateral this time. Along with this, there is myelitis also. What is Marburg variant? I just told you this. It is a fulminant type of MS which doesn't resolve at all. It's a very serious patient. It's a variant of MS. Myelitis. Myelitis means inflammation of the spinal cord And don't forget, in patients of MS, it's a severe myelitis that we find, one. Secondly, it occurs across the spinal cord in a section transverse. And most important, 3 or more than 3 longitudinal segments are involved in these patients. So segments of a spinal cord, when I look at, like for example, I take it as thoracic T1, T2, T3. So that is something which is in a consecutive way involved in them, 3 or more than 3 longitudinal segments. Okay. Most important, remember this, these episodes of optic neuritis, which may be bilateral and myelitis both, are recurrent, one. But there is some fugax, don't panic. There's some fugax, don't panic. There's some fugax, don't panic. But to a larger extent, non-progressive. Non-progressive. Okay. That means it doesn't try to increase. Like for example, in an MS patient, I was really scared of that patient. He had a demyelinating lesion and it kept on progressing with time. But this time, most of the time, they are non-progressive. They might be recurrent and they will never happen over. They might happen over and over again, but they are non-progressive kind of lesions. Along with this, do remember this, hypothalamic lesions happen in them. Hypothalamic lesions do happen in these patients. For example, endocrinopathies. If you know, the hypothalamus is a big boss of the endocrine system. It gives me a lot of releasing hormones for the other hormones to come out. So those releasing hormones are not coming out now. So they suffer with a deficiency of various endocrine hormones or endocrinopathies. Transverse means across the spinal cord. If I look at the spinal cord transversely, all across it I will find a loss of the spinal cord. Okay. What does the longitudinal mean? If it is a T1, T2 and T3 segment, all 3 of them will be involved in a longitudinal way. Okay. Apart from this, there is an area involved in them known as area postrema. Now this area postrema which you find is involved in them, causing a lot of hiccups and vomiting. If you remember, this is quite close to that chemo trigger zone, right? So there can be some problem here and there can be a lot of hiccups and vomiting in the patient. Along with this, in these patients, don't forget something very important which has been recently asked in all the exams last year. Aquaporin 4 channel antibodies are found. So we find these channels which are reabsorbing water for me, known as the aquaporin AQP. AQP4 antibodies are seen in these patients. They are somewhere positive, write it down, in nearly 75% of NMO patients. So 75% of these patients do get these antibodies positive. Aquaporin 4. Can you guide me whether this aquaporin 4 is present? If you remember the aquaporin channels that we have, the aquaporin 1, the aquaporin 2, the aquaporin 3 and the aquaporin 4. Any ideas? If I make this as a collecting duct cell of the kidney, yes, CD, there is an aquaporin 2 present on this end. Yes, that is actually reabsorbing water for me. On the other side is aquaporin 3 and aquaporin 4. So what is the major difference now? This is the side where the urine is flowing out, is a luminal side where the aquaporin 2 is seen. On the other side where the blood is present is known as a basolateral membrane. Good. People do it. Happy. Now, where is the aquaporin 1 present? If you remember physiology, it is present not in the collecting duct cell, it is present in the PCT. Now, please guide me, if there is an antibody to aquaporin 4, what is going to happen next? If I get an antibody to the aquaporin 4 channel, what is going to happen? Any ideas? Any disease you can tell me? Oh, water reabsorption will not happen. Excellent. And a disease might come in where a lot of water is lost out in the urine. Yeah, diuresis, polyuria, diabetes insipidus. That means this patient will suffer with diabetes insipidus now. Okay. 2 minutes of silence for your knowledge and IQ. The answer is not diabetes insipidus, my dear friend. The acuprine 4 channel in this patient is nowhere involved in this thing. Cut it out. It was just for explanation and confusing you. Okay. Some emesis fugax happened. Don't panic. All is well. Now look at this. There's a vessel of the brain flowing with blood. And now we have got astrocyte over there. Astrocyte is a venger which looks like this. It sits on the vessel to form the blood-brain barrier with a foot plate. Now we find somewhere the foot plate of the astrocytes are having these acuprine 4 channels. So if we got antibodies against the acuprine 4 channels, they will come and attack it. And what are they going to disrupt? The blood-brain barrier. Simple. So please, my dear friend, it has nothing to do with DI and all that thing that you were thinking about. Okay. So antibodies against acuprine 4 channel are aggregating on the astrocyte and disrupting the blood-brain barrier. Simple. या आपके साथ आज एक बहुत बड़ा प्रैंक हुआ. Okay, simple. Now, look at the investigation, please. Few points about investigation. Again, I'll not go into the MRI part. That will be dealt by sir in radiology. CSF. In patients of NMO, please remember, there is pleocytosis seen most of the time. So there is a rise in cell count in these patients more often seen. Just a point to write over here. The oligoclonal band is quite routinely absent in these patients. Oligoclonal bands is quite routinely absent in them. They are very uncommon in these patients. Don't forget this. But these patients of NMO are often seen to be associated with other disorders like, please remember this has come recently, autoimmune disease like SLE, 1, Sjogren's syndrome, okay, even myasthenia gravis and Hashimoto's, thyroiditis. So please remember they are often associated with these kinds of disorders most of the time. And also some kind of infections are preceding this. That is varicella zoster virus, Epstein-Barr virus, HIV also. Never know, another 1 year I'll tell coronavirus also. Okay. So these are few viruses which are associated and few autoimmune disorders which are seen with it. Now when I go for a treatment part, do remember this. We do follow the same thing that we followed up in patients of MS. We treat the acute attack and then we give some prophylaxis therapy. So remember this, in NMO patient, an acute attack. Acute attack of NMO, we give the patient methylprednisolone. Methylprednisolone. Okay. In the methylpred, what do we find? We give the same dose, everything. But if there is no response, we go in for the plasmapheresis. Again, I repeat, in patients of NMO, the drug of choice for acute attack is again your methylpred. Okay. Go slow, understanding. Dheere, dheere. Oligoclonal band, OCB, oligoclonal band. Okay, forgot just now. Just told you. Agarose gel electrophoresis. Agarose gel. My English is improving. Okay, now we have got drugs for prophylaxis. The drugs for prophylaxis, please remember, in these patients is mycophenolate mofetil, being abbreviated to me as a word MMF. Please do remember, mycophenolate mofetil is used in them. In these patients, even rituximab is used. Rituximab is used. Or we can also give azathioprine to them. So just remember the names of these drugs, not too much about them. Mycophenolate mofetil, rituximab and azathioprine are the three drugs used for them. Okay. Please do remember this extra point which has been asked last year, that interferon beta, the other drugs which I know as the glatiramer, even the fingolimod, and even the natalizumab. So all the drugs of MS that we have used, which were very good, highly effective, maybe some of them, is not effective in patients of NMO. So the point here is that a patient of optic neuritis comes to me with a bilateral visual loss. Suddenly he develops both lower limb weak due to transverse myelitis known as paraparesis, and he also documents to have an acroporin 4 channel antibody. It's not a case of MS, it's a case of NMO. Okay. See, oligoclonal bands are something which will come in the CSF in MS patients also, only, not in them. So there were some IgG antibodies which were there in MS patient, if you remember, right? So those IgG antibodies in patients of MS in the CSF will precipitate on the agarose gel electrophoresis to precipitate in form of a oligoclonal band. Okay. Yeah, rituximab can cause this problem, no doubt. Okay. Can cause this PMLE disease. NTZ, yaar, kya? Natalizumab. You guys actually want a lot of spoon feeding. Not spoon feeding, rice tube feeding. You don't want to open your mouth also. Rice tube feeding you guys right. So please grow up. Okay. Now a topic that is very important, which I left out in the previous classes. Okay. Is which everyone is asking me the moment I start the class, is cryptococcal meningitis. Some student told me, sir, you are very sarcastic to the students. How dare you? A teacher should always motivate us. Eh? I said my teacher should always show me a mirror, how good and bad I am. Then only I'll feel motivated myself. If he keeps on giving me some kind of appreciation unnecessarily, it is not going to help me. Okay. Now, cryptococcal meningitis, very important. Cryptococcal meningitis. Now, this is something important because it's, write it down, few points. It's the most common cause of meningitis in HIV positive patients. Okay, HIV positive patient, when I look at the most common cause of meningitis is always a cryptococcal meningitis. Now, the organism which we know, the organism that we have which is somewhere causing this is a fungus, right? Now the name of this fungal species is Cryptococcus neoformans, which is an encapsulated yeast. If you remember this organism, Cryptococcus neoformans, it's actually an encapsulated yeast which is somewhere found in the soil as well as the avian droppings. So where do we get it from? From the soil as well as the avian droppings, an encapsulated yeast which is known as the Cryptococcus neoformans. Somewhere we find it's the most common meningitis in HIV positive patients, the cause. Now how does this organism enter into us? It's a very simple thing. The entry of this organism, okay, is via the lung most of the time, the lung. And we find with the patient they have got asymptomatic pneumonia to begin with. So the pneumonia that we have because of this kind of a fungal species is found to be asymptomatic in them. They just keep there. What is avian droppings? Great question. It is the fecal matter of the birds, okay, which try to fall down somewhere, avian droppings. Then we have the hematogenous spread of this. So the avian dropping, if you remember, is a good omen. Sometimes the shit can be a bad omen, that is a bird shit, okay, can be a bad omen also if it carries that fungus Cryptococcus inside it, right? I don't know, we have got some Alia Bhatts and Rahul Gandhi in the batch today. Oh my god. Lodge in the central nervous system. Okay, so that was the jokes for the bucks, they can enjoy the joke. Lodge in the central nervous system. Now after the asymptomatic pneumonia, it goes into the blood and lodges itself into the central nervous system. And then finally, we have the cryptococcal meningitis in these cases. Okay, right. Do remember a clinical point. Cryptococcal meningitis is a late complication in HIV patients, especially CD4 count, if at all, is less than 100. Then only we find this problem coming in. If the CD4 count is less than 100, okay, so it's a late complication. Don't know, my family members keep on doing their own work whenever I am teaching. They are not worried, they are just cooking food for the day. Clinical features. Okay, clinical features. Do remember, these patients most of the time have got a non-specific kind of a headache. With fever also. So a non-specific kind of a headache and a fever is found in these patients. Apart from this, they do have a symptom of vomiting, photophobia, and of course, sixth nerve palsy. All these things will happen whenever you have a raised ICT kind of a drama in these patients. Okay. And. Just write this word, this has come recently. Seizure or any kind of a focal neurological deficit. Please do remember this. Any kind of a focal neurological deficit or seizure in these patients are obviously and commonly found to be rare. Not so common, it's quite rare in these patients. Okay. Please remember this fact. This has been asked 2 years back, I remember. Any new onset headache or any kind of a CNS symptom, any new kinds of headache or a CNS symptom in late stages of HIV, okay, requires workup for cryptococcal meningitis. Correct? So this was a question that in the late stage of HIV infection, a patient came in with a new onset headache, CNS symptom. What are you going to investigate for? TBM, viral or fungal? Always fungal. Remember this. Always fungal. As far as what we find is that any sign which we saw in the previous classes of meningitis, neck rigidity, Carnegie's, Brudzinski, all those signs are yes, they are seen in these patients also. Okay. Right. Now let's move into the investigation part and see the CSF in these patients. CSF. In patients of cryptococcal meningitis, we find mild to moderate pleocytosis. So pleocytosis, that means rise in the cell count is seen in them, which is mild to moderate. Okay. And now can you guys tell me, if you apply your mind, you will be able to solve this question. What are we going to have more, lymphocytes or the neutrophils? Yeah, asymptomatic due to low immunity. Yes, good. But if at all pleocytosis happens in cryptococcal meningitis, okay, yeah, it's a chronic infection every time. It's going to be a lymphocytic picture most of the time. Okay. Also in these patients we find mild protein increase in the CSF. Yes. And most of the time we might see a normal glucose. If you remember, the very low CSF glucose happened in a pyogenic, slightly low happened in TBM, normal went in viral as well as fungal also to add to it. Okay. And some of the patients we might find that the CSF could be normal also, but that's a typical picture that we find. What is a staining that you use for looking at these patients? Can you tell me the stain that you use for these patients in the CSF to look at the organism? Can you tell me the stain? It's the India ink stain. So we do the staining with the India ink in which we try to check out for the virus. Okay, the staining. Okay. Please remember, we might also get the serum cryptococcal antigen then in them. Serum cryptococcal antigen is also done in these patients. And they found in a study that it is often positive. Okay. Almost 3 weeks prior to meningitis. So whatever meningitis that we are having, 3 weeks prior to it, we find a cryptococcal antigen in the blood seen in them. Now it's not the CSF antigen of cryptococcus, it's serum cryptococcal antigen. Okay. But at all, if actually in clinical practice we don't use this one. We only use it whenever we have a contraindication for doing a lumbar puncture or maybe something is of that sort. Only then. MRI. If you remember the MRI, yes, they have got enlarged Virchow Robin spaces in patients of cryptococcal meningitis. Now, what is Virchow Robin spaces and all these things? You learn this better in your radio classes. I'll again keep it for the wisdom of Sumesh sir to teach that topic. Okay, you'll be looking all these things into the MRI, then only you'll learn it better. Right. Now comes the treatment part, because all these are one-liners kind of thing that we find. In cryptococcal meningitis, most of the one-liners have been coming. Now the treatment part. Do remember, if a patient comes to me with a CNS manifestation or a cryptococcal meningitis, I usually start it with an induction therapy. There is an induction treatment that we induce the patient with initially to start the treatment. Induction. Okay. Induction is most of the time done with a drug, amphotericin B. Okay. It's obviously given through the route IV intravenous, along with a drug which is flucytosine. So a combination of amphotericin B with flucytosine oblique fluconazole can be used in them. Now don't try to remember the doses, it's very difficult at your level. Just remember the name of these drugs: flucytosine, fluconazole, either of the two with amphotericin B is added in the patient. Then we repeat the CSF. Okay. If at all the CSF gets sterile. Now when do we repeat the CSF? That's very important. 2 weeks time. We give these drugs for 2 weeks time. Okay. Then we repeat the CSF of the patient. If the CSF got sterile, sorry, we go with a standard drug, fluconazole, through the route oral for another 8 weeks time. So total duration of fluconazole, if at all I have to give, it has to be 2 plus 8, 10 weeks time. Okay. After this, I'll continue with fluconazole. Of course, we are giving it oral. I'm writing the word oral over here. I'm not using the word IV now. It's oral fluconazole that we give to the patient. Some of the authors say give it lifelong, it's always better. Or if the CD4 count is above 200 then. So do remember this, fluconazole, you can give it lifelong. There is a good thing for the patient also, you will not catch it again. But if the CD4 count is more than 200, you can think of stopping it. Okay. So that's the standard guidelines that we have for management of cryptococcal meningitis. Right. Just a second. As usual, we have got some questions with us. We'll try to see this. Yeah, Bell Baji Chutti. People are so happy to go home. Tomorrow we will start with Parkinsonism and movement disorder, and don't miss that class. It's a very high and interesting class, going to be very interesting. I'm going to record some videos with my mother, of course, and my wife, and then we will I'll show you some kind of videos which with the various movement disorders have. Okay, so look at this question. Which type of multiple sclerosis is depicted in the image? Yeah, good answer. Correct answer is SPMS. Please remember this word PRMS is no more. Okay, there's no term like PRMS now. We have removed that thing. The RRMS wala will look like this, if you remember, and the PPMS wala will look like this. But a student asked me in between, sir, look at this. No, this is increasing, so it is progressive also between the relapses. No. See, we remember this. Whenever I find a patient of RRMS, anytime, in between the relapses, the patient often remains stable, like in this case. He's been stable in between the relapses. Okay? And now, then suddenly a shoot up happened. That's known as SPMS. That's a very simple one. Okay, there's a doubt on cryptococcal meningitis. If the CSF is not sterile, then what do I do, sir? Continue. Continue. Let it continue till you get a CSF that is sterile. Now question number 2 is an easy one. A young woman in her early 20s experiences loss of sensation in her legs and weakness in her limbs. A neurological examination reveals some spasticity of the limb as well. Oh, that's repeated. There's some echolalia here. Okay, there's some echolalia here. Okay, and neurologist makes a preliminary diagnosis of an early MS in this case. Assuming that this diagnosis is correct, which of the following best accounts for the diminution of sensory and motor functions? Please tell me. What is the problem in these patients? Is it the Schwann cell which has been lost in the peripheral nervous system? Is it the decrease in the dopaminergic release? Is it a peripheral cholinergic neurons, or is it demyelination? It's a demyelination of the central nervous system. Correct. Easy answer. Now this one. Oh God. Looks to be a difficult question, but I'll try to make this one also easy. A 41-year-old man with a relapsing remitting MS for nearly 20 years on optic neuritis and spastic paraparesis with a partial recovery. Patient's bladder is likely to reveal which of the following abnormalities. Now look at this. Once you get spasticity in the lower limb, there is going to be spasticity in the smooth muscles around the lower limb, that is the bladder also. So that's a quick look at this patient. A patient of MS is going to have spasticity on the bladder. Now tell me, if the bladder is contracted most of the time, what will happen? Bladder hypertonia, large residual urine of volume of urine, premature bladder emptying, or a urinary tract infection. Guess it. If the bladder is hypertonic due to spasticity, the detrusal muscle is contracting most of the time. The patient will have urge to pass urine and will come out with urine before they reach the toilet. The urge incontinence, the premature bladder emptying. Not UTI. UTI is not the very correct answer here, please. It's a very non-specific thing. So they say somewhere there is a detrusal muscle contraction which increases in patients of MS. And most of the time they have a contracted bladder with a premature bladder emptying. Okay. Right. Okay. Which of the following is true about MS? Which of the following is true about MS? Seizure are absent in MS. Tell me yes or yes. See, the problem is in MS, whenever you have a plaque-like thing which tries to collect, at the area, suddenly you find that in this plaque-like thing, okay, there is an area of demyelination with a sclerosis. And this plaque-like thing will always create an epileptogenic focus itself, because this plaque or an area of no remyelination or maybe a scarring in the brain, in the long run in the central nervous system, yes, will be an epileptogenic focus. Please remember this. So seizure can happen. Now this is the confusion that you might have. B cells produce antibody against the exons. Read it again somewhere in the books. Exons in patients of MS are normal. Actually, they are untouched by the disease. There is no axonal degeneration as such seen in these patients. It's just the loss of myelin surrounding that thing. 1 in 25 risk if the parent is affected. No. It is 1 in how much? 1 in 50? Yes. 1 in 50 risk. Fingolimod is a moderately effective disease modifying agent. Correct statement. Okay. Now this one. A 24-year-old man has multiple sclerosis, recovered from left optic neuritis a year earlier, and more recently has developed progressive ataxia. When considering the prognosis of MS, which is likely to be a benign course of the disease, what is the thing which happened at the onset in the patient's life? That made me think that he is going to carry a good prognosis. Please tell that now. Please tell me that. Yes, sensory symptoms at the onset or even optic neuritis at the onset always carries a good prognosis in the patient. Okay? Simple answer, clear answer. Oh, sorry. My mistake. There was some equal area and the question got repeated here. I'm sorry. Okay. One question got deleted somewhere actually. I don't know. I'm typing. Which of the following sentence is correct regarding NMO? Please tell me that. Which of the following sentence is correct regarding NMO? Symptoms are progressive in nature? No. Males are more commonly affected than the females? No, it's female more common than the males. Oligoclonal bands are common in them? No. Is it astrocytopathy? True. It involves the astrocytes because the antibodies are somewhere seen at the foot plates of the astrocyte against the aquaporin 4 channel. Okay. So all well that tries to end well. Okay. We learned a lot of new things today, especially McDonald. And when I wrote McDonald, people thought of McDonald, which has been closed right now to the lockdown. But there is a Haldiram in America. I always call McDonald as the American Haldiram. Okay. So he is wishing you to stay home and stay safe. Stay home and stay safe. Very important. Okay. And tomorrow topic will be movement disorders and Parkinsonism. So American Haldiram is greeting you. That will open up whenever required. Okay. Please post your queries on the Facebook club in today's post, which I put on multiple sclerosis. Okay. Yeah, God bless America. God bless you guys also. Please go through the question paper in the snapshot in that Facebook page also, because I have just missed one question here. I don't know. I did not come in the display, and I'll just put one extra question there. Okay, just be in tune with me. And please, my apologies if I'm not able to answer some of your queries so rapidly like you ask. Because see, at the end of the day, I'm a family man. I have to do a lot of work, let my kids do the homework, do cleaning, make food. So a lot of responsibilities at the kind of a lockdown is with me, right? So I'll answer all your queries, don't worry. Okay, good night. Stay home, stay safe.